Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenters are Denise Lynch and Elisa Curry. Denise Lynch is a registered nurse and stroke program coordinator at Washington Hospital. Elisa Curry is a physical therapist and coordinator of rehab clinical programs at Washington Hospital.
Thank you everyone for coming out and listening to our presentation tonight about recovering after a stroke, a patient and family guide. Let's sort of get started here. So what I'm going to do is I'm going to go over a brief overview of stroke and the treatment, and then the effects following a stroke, and then some tips on how to navigate the recovery process. So some facts first about stroke. There are nearly 800,000 strokes per year. Stroke is actually the 5th leading cause of death in the U.S. One person dies of stroke every 4 minutes. And there are more than 4.5 million stroke survivors living in the U.S. Stroke is actually the leading cause of serious long-term disability and preventable disability. 80% of strokes are actually preventable. 40% are left with moderate impairment, and about 15 to 30% are left with severe impairment. Only 50 to 70% of stroke survivors regain functional independence. 20% are institutionalized within 3 months. 22% of men and 25% of women die within the first year of having a stroke. Locally, African Americans have 50% more strokes than Caucasians and twice as many as Asians and Hispanics. So women in stroke. Stroke actually kills more women than men. So a woman who is 30 years old and who smokes and is on oral contraceptives are 22 times more likely to have a stroke. And this is a huge fact. Stroke kills more than twice as many American women every year as breast cancer, ovarian cancer, uterine, and cervical cancer combined. Okay, so let's talk about the 2 different types of strokes that there are. There are what we call an ischemic stroke, and the other one is called a hemorrhagic stroke. An ischemic stroke is caused by a blood clot that disrupts the flow of blood in the blood vessel. And so the blood, the nutrients in the blood, the oxygen can't get to the brain cells, and the brain cells die, and that is your stroke. The other one, being a hemorrhagic stroke, is when a weakened blood vessel bursts and blood goes into the brain. It's about an 80-20. There's more ischemic strokes than hemorrhagic strokes. So what is a TIA? A TIA is a transient ischemic attack. It's a mini stroke. It's stroke-like symptoms that go away within 24 hours. And it's estimated that between 200 and 500,000 occur annually. And these are really important because 9 to 20% of those patients that have a TIA, they may go on to have a stroke in the next 90 days. So here at Washington Hospital, we take that very seriously, and all our suspected TIA patients are brought into the hospital, and a full stroke workup is done on these patients to determine if there's any risk for stroke. Okay, so risk factors for ischemic strokes. You have uncontrollable risk factors and controllable risk factors. Uncontrollable are those things that we really can't do anything about, such as our age, our gender, our race, our genetics. We want to look at our controllable risk factors. What can we control? So those things being high blood pressure, high cholesterol, diabetes, atrial fibrillation, smoking, lack of exercise, obesity, and excessive alcohol or drug usage. Common signs and symptoms of stroke. So the key word here, as you can see, is sudden. It's sudden onset of weakness or numbness on one side of the body. It's a sudden headache, no headache like you've ever had before, with no known cause. It could be a sudden onset of confusion, trouble getting your words out, trouble understanding. It could be trouble seeing in one or both eyes, trouble walking, dizziness, loss of balance, coordination issues. So depending on where the stroke occurs in the brain is sort of your symptoms. So for example, if you have a stroke in your frontal lobe, you're going to have more cognitive problems. If you have a stroke in your parietal lobes, you're going to have more of motor sensation symptoms. Another example might be the occipital lobe back here. That's where your vision is. So you might have trouble seeing in one or both eyes. Now, if their stroke occurs in your left brain, the tracks cross over and affect the right-hand side of your body, and vice versa. Right hemisphere affect the left-hand side of the body. Time is so important with the brain. So that is why it's so important that if you think you or somebody else is having a stroke, is that you dial 911 and you get to the hospital as fast as you can. We have to remember that for every minute the brain is left untreated, there is 1.9 million brain cells that will die. So the faster you treat the brain, the better your outcome is. Now this is a slide of a CT scan of small ischemic stroke. So here you say this is the person lying down, right face up. You have the right hemisphere, and this is your left hemisphere. And this black area right here is where there's a small ischemic stroke. Shows up black on a CT scan. This right here is a very large ischemic stroke in the right hemisphere. Remember, this is left hemisphere. And you can see it's even pushing over onto the left hemisphere. This is a very severe stroke, may not be survivable. Stroke assessment scales. So there are many different types of stroke assessment scales that can kind of determine whether or not the person's having a stroke. The two that I'm going to talk about is the Cincinnati and FAST. So the Cincinnati Pre-Hospital Stroke Scale is actually the scale that is used out in the field for EMS, Emergency Medical Services. So what they do is they look at the face, they have the patient smile. Is it symmetrical? Is it asymmetrical? Is there a little bit of facial weakness? You want to look at the folds in the face. Then they ask the person to put their arms out and hold it for 10 seconds. Is there some drift? Is there some weakness? Can they maybe not even lift their arm? And then they ask them to repeat after me. The sky is blue in Cincinnati. So if they can't get those words out, or it's slurred, or it makes no sense whatsoever, that could be a sign of a stroke. And this tool is actually 80% reliable. The other one is FAST. You may have seen this hopefully on commercials and stuff, the acronym FAST, F-A-S-T. It stands for face again, arms, is there weakness, speech, is it clear or not, and time. So if you're on the outside of the hospital, of course you dial 911, get to the hospital as soon as you can. And then if you're inside the hospital, we use this and we call codes and such things like that. And the real important thing here is knowing when the person was last seen normal. That makes the difference in treatment. So say you're having a stroke, you come through our emergency room, you come through the front doors, and obviously an ER physician comes and sees you quickly. There's nurses, you get your lab drawn, you get EKGs done. And then we take you off to imaging. Imaging gives us a lot of information. So we do what's called a CT scan of the brain, we do a CT perfusion, and we do a CT angiogram on most of our patients. And again, this is just a normal CT scan. We're looking to see, is the patient having an acute ischemic stroke? That might show up on CT. Are they having a hemorrhagic stroke? That tells us information on how we're going to treat the patient. Here is a CT perfusion. So with all the technology we have, this is amazing, is see this blue area right here? This is actually showing us that there are brain cells that are dying. They're not dead. We can't do anything with dead tissue, but this is dying tissue. So this is salvageable tissue. We actually call it penumbra. And so this is somebody that we want to actively treat if they meet the requirements. And then a CT angiogram. CT angiogram is when we inject contrast into your IV. And the contrast goes through your blood system, goes up to the brain, it highlights the blood vessels, and it can show us if there's a clot there. So by looking at this, you see that this is the right side. You see the blood vessels nicely, but it does look asymmetrical. You don't see here, you don't see it go out here. Well, in fact, there's a blood clot sitting right there. And so, okay, so what can be done for an acute stroke? So if you come to the hospital with symptom onset less than 4.5 hours, you can get what's called tissue plasminogen activator, TPA. So it's a clot busting agent. We give it through the IV and it dissolves the clot. But you have to meet all of the stringent criteria in order for us to give it. And here at Washington, our goal is to be able to give that to you within 45 minutes of walking in the front door. The other approaches is what called interventional approaches. So here at Washington, we have specialized doctors that can actually go up to the brain and get the clot. So what they do is they make a small incision in your groin. They run a catheter all the way up to where that clot is in the brain. And mind you, the vessels in the brain are very tiny. They use devices such as the retrieval, the penumbra device, and they're able to extract that clot out of the brain. And here's an image of a clot that was pulled out of the brain. And then you can see on imaging, right? So you can see the clot was right there. There's no blood flow. That brain tissue is dying. And then here, after the doctor was able to pull that clot out, the flow was restored. Revascularization occurs. That brain tissue is not dying any longer. Okay, so let's talk a little bit about hemorrhagic stroke. Hemorrhagic strokes, unfortunately, are more likely to result in death and severe disability. There's about 37,000 hemorrhagic strokes per year. 35 to 52 are actually dead within 1 month, and only 10% are living independently after 1 month. So what are the risk factors for hemorrhagic strokes? Hypertension being the #1 thing. Advancing age, right? As we get older, our blood vessels get a little bit weakened, maybe coagulopathy disorders, alcohol abuse, drug use, methamphetamine, cocaine, that all weakens blood vessels, and also the ischemic stroke. So if you have, like that one slide that I showed you, that very large ischemic stroke, that area is at risk for bleeding, so you could have a hemorrhagic stroke in that area. Presenting signs. So the #1 thing is a severe headache, like I said, like you've never had before. Oftentimes they come in the emergency room, they're nauseated, they're vomiting, they have decreasing level of consciousness, they're often very sleepy, or they're in a coma, and they have extremely high blood pressures. It's not uncommon for someone to come in with a blood pressure of 258 over 150. Okay, so on CT scan, blood shows up as being white. So that's actually in the right basal ganglia, very small hemorrhagic stroke. That's typical of a hypertensive bleed. And then this is a very large hemorrhagic stroke. You see where the white is. This is quite alarming. So the treatment options for hemorrhagic strokes are usually conservative. What we want to do is we want to drive the blood pressure down from where it was, because that stops the bleeding. If the blood is more towards the surface of the brain, the neurosurgeon may be able to take that blood out, take that blood clot out. Sometimes they can put a drain into the ventricle. The ventricle is where the cerebral spinal fluid is, and they're able to drain out the blood that way. Sometimes they'll correct the coagulopathies, but again, managing the blood pressure is key. The effects of stroke. So problems associated after having a stroke. Well, there's emotional problems, inadequate ventilation, disorders of sensation, and I'm going to go through all of these one by one real quick here. So definitely emotional problems and social deprivation, right? There's definitely, after having a stroke, there's a change in body image. There's loss of independence. There can be a pain associated with the stroke. If the person was to get a contracture or something, they can get pain in the shoulder or the elbow. They could have altered ability to communicate, and this all leads to isolation. So unfortunately, depression is the most serious complication of stroke. They estimate that about 50% of stroke patients will have signs of depression in the few months following a stroke. And this can either be because of the stroke, obviously having the stroke caused depression, or it can be actually a biochemical problem in the brain. And oftentimes it'll manifest itself in patient will have fatigue, they may have sleepiness or a poor appetite, or they may actually say, why me? So inadequate ventilation of the lungs. So some stroke patients will have dysphagia, and that is trouble swallowing. So if you have abnormal tone in your face, if you have facial weakness, you're at risk for not being able to eat correctly, right? You may choke, you may cough, you may pocket your food. And if the food doesn't go into your stomach and inadvertently goes into your lungs, you may acquire aspiration pneumonia. And this is actually the leading cause of death in stroke patients. Disorders of sensation. Okay, so if you have numbness or complete numbness to one side of the body, maybe you're making breakfast in the morning, trying to get yourself some breakfast, and you inadvertently put your hand on the burner, and it takes a while for that impulse to get to the brain because you have no sensation there. It can lead to burns and skin breakdown and infections. Incontinence of bowel and bladder. So 50% of stroke patients will have incontinence in the acute phase. This often leads to embarrassment. Sometimes it's hard for the family or caregivers to sort of deal with this. It can lead to skin breakdown. Communication. Forming clear language can be impossible sometimes. Sometimes patients with aphasia, they can't get any of their words out. They may not even be able to nod yes or no to you. And maybe they're not able to understand what is being told to them or asked of them. And this can lead to isolation as well. Abnormal tone. So if someone has weakness on one side or paralysis, that makes it very difficult to walk and take care of themselves. This leads to dysfunction and impaired hygiene, altered body image, certainly. So what's the answer? The answer is rehabilitation. And at Washington, that's the first thing that we think about is after the acute phase, we want to get in there, our physical therapists, occupational therapists. Effective rehabilitation interventions initiated early after stroke enhance the recovery process and minimize functional disability. So our goals here at Washington, rehab, we want to prevent another stroke from ever happening. So we try to identify what caused the stroke. Maybe it was blood pressure. Maybe you hadn't seen your doctor in a couple of years and you've been walking around with high blood pressure, and now we've put you on some medication for that. And we want to prevent complications, certainly, like the aspiration I talked about, and maintain safety. So after the acute phase of being in the hospital, we want to get you ready to go to acute rehab. And this is a place where you go and you exercise morning to night, and it's generally about a 3-week stay or so. And the rehab team consists of doctors and nurses, physical therapists, occupational therapists, speech therapists, etc. But the patient and the family are key members of this team. So the golden window of opportunity, they say the first 2 months after having the stroke are when you get your most improvement back. I've talked to a lot of stroke survivors, and they say You know what? Tell your survivors, don't give up. Don't give up. Stay the course, because they find that they improve 1 year, 2 year. I was just talking to a gentleman the other day, and he had severe aphasia, and I had no idea he had a stroke. He says it's been 10 years, and every day I'm still getting better and better, you know? So I was like, wow. Another alternative could be home rehabilitation. So therapists can come out to your home, they evaluate your home, make sure everything's safe. The first thing they want to do is remove all those throw rugs. Those are a trip hazard. Make sure that you're wearing good shoes. Perhaps you need handrails in the bathroom, in the shower, where the commode is. They can also provide medical equipment, wheelchair or walkers. So continued goals: to increase independence, improve cognitive and physical function, improve communication, maintain safety, prevent another stroke, and achieve a satisfactory quality of life. Okay, so now let's talk a little bit about the caregiver. Living with stroke is so intimately associated with caregiving of the stroke survivor. We must consider both the survivor and the caregiver. The caregiver is generally a spouse. Caregivers have a major influence on the long-term well-being of stroke survivors. They help to maintain and the gains achieved while in rehab. And because rehab has done so much to improve stroke-induced disabilities, 80% of stroke survivors do return home. Caregivers typically get minimal education. There's no really any classes out there that tell us how to be good caregivers. The studies highlight the limited use of services available. There's not a whole lot of resources out there. Caregiving is usually a long-term for the stroke survivor. So who's the average caregiver? It's, like I said, it's typically a spouse. Maybe they're somewhere between the 5th and 7th decade, and many may have health issues of their own. So it's really important for us to understand that both the stroke survivor and the caregiver have profound sense of loss, right? The stroke survivor definitely has a sense of loss of independence. They can't do things like they used to be able to do. And then the caregiver, maybe they don't have the leisure time that they once had. They have loss of freedom. Another problem is relationship adjustments, right? Maybe pre-stroke the marriage was hopefully a partnership, right? And now it's become caregiver, care receiver. New responsibilities. So maybe now all of a sudden as caregiver, you're not just doing all of that work, but you're also maybe the breadwinner now. And maybe you weren't before the other person had the stroke. Now maybe you're making all the decisions, financial decisions, whatever decisions. Feeling the demand of caregiving. Caregiving is hard work, there's no doubt about it. And sometimes we're poorly prepared to take on that role. Caregiver health is often adversely affected. So it's hard to have to depend on others. It's difficult to ask for help, but we have to be able to ask for help when we need it. Good outcomes embrace the new relationships and contact with others. So hope and optimism. Stroke survivors must maintain hope to help improve function and overcome barriers. You need to have a positive attitude. You need to stay the course. So the caregiver, helping someone you care for to continue living independently in the community is valuable work. Caregiving can be satisfying experience. It demonstrates fulfillment of a commitment to a loved one. True enough, though, caregiving is not a role anyone really chooses. It seems to choose us, emerging from events and circumstances outside our expectations and beyond our control. So, a few tips to navigate the recovery process. So, you need, as a caregiver, you need to ask questions. You need to get all the information you possibly can. You want to know, what type of stroke did my loved one have? What caused the stroke? How can we prevent it? What are the long-term effects of this stroke? And a couple of sources here. I highly recommend that you visit the website Stroke Association. There's lots of information on that website for caregivers. There is also a hotline of 1-888-4-STROKE, and it's called the Stroke Family Warm Line. And this is actually staffed by people that are very knowledgeable in stroke, actually have personal experience with stroke. And it's a really good resource. And you can ask questions, or maybe you just need to talk. Okay, so some other tips for the caregiver. It's so important. You've got to reach out to family and friends and ask for help. You can't do it all by yourself. And you got to take care of yourself, right? So that means calling up a friend and going to get a cup of coffee, or going to the movies with a friend. It's also very important that you build a network, right, with other stroke survivors. So here at Washington, we have an excellent stroke support group that meets the